Assalamu alaikum. I am Hadeel Hisham. I will start my presentation by talking about ischemic heart disease, which is most common important branch of cardiovascular disorders. And the topic is represented by me and by my colleagues. So listen to us and focus. We were talking about ischemic heart disease and its classifications. So what do we mean by ischemic heart disease? It's a condition where there is an imbalance between cardiac blood supply and myocardial oxygen and the nutritional requirements, which is associated with ischemia and hypoxia. One of the most common causes of ischemic heart disease is atherosclerosis, where the blood vessels of the heart are narrowed or blocked due to deposition of cholesterol plaques on their walls. This reduces the supply of oxygen and the nutrient to the heart musculature, which is essential for proper heart functioning. Since cardiac myocytes generate energy almost through mitochondrial oxidative phosphorylation, cardiac function is strictly dependent upon the continuous flow of oxygenated blood through the coronary arteries. Ischemic heart disease in its various forms remains the leading cause of death in the United States and other developed nations, accounting for 7.5 million deaths worldwide each year. There are 4 categories of ischemic heart disease. Angina pectoris, which appear as chest pain. Ischemia induces pain but is insufficient to cause myocyte death. Acute myocardial infarction. This occurs when the severity or duration of ischemia is sufficient to cause cardiomyocyte death. Chronic ischemic heart disease. This is progressive cardiac decompensation, which occur after acute MI. And sudden cardiac death. This can occur as a consequence of tissue damage from MI, but must commonly result from a lethal arrhythmia without myocyte necrosis. We know the term acute coronary syndrome that's applied to any of the 3 catastrophic manifestations of ischemic heart disease: unstable angina, myocardial infarction, and sudden cardiac death. And now, pathogenesis. How it happened. A multitude of factors are responsible for the development of ischemic heart disease. It developed as a consequence of inadequate coronary perfusion relative to myocardial demand, usually as a consequence of pre-existing atherosclerotic occlusion of the coronary arteries and the new superimposed thrombosis and vasospasm. Atherosclerotic narrowing can affect any of the coronary arteries: left anterior descending, left circumflex, and right coronary artery. Clinically, significant plaques tend to occur within the first several centimeters of the left anterior descending and left circumflex, take off from the aorta and along the entire length of right coronary artery. And these are the other causes or risk factors that develop ischemic heart disease. Those patients with hypercholesterolemia have much higher incidence to develop the disease. There is also theory that hypertension is a risk factor in the development of ischemic heart disease. Genetic factors, smoking, sedentary lifestyle are also associated with emergence of ischemic heart disease. Obesity and type 2 diabetes mellitus are increasing and are powerful risk factors for ischemic heart disease. And hereditary factors may also be responsible. And stress also thought to be a risk factor. And now the continuation will be by my colleague Neam.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Neam, and my section in this presentation is to talk about the first clinical type of ischemic heart disease, which is angina pectoris. So what do we mean by angina? Angina comes from the Latin word angere, which is to strangle, while pectoris comes from the word pectus, which is the chest. So it is a condition of strangling the chest. And by definition, it is an intermittent chest pain that's caused by transient, that's to say less than 15-minute reversible myocardial ischemia that's insufficient to cause myocyte death. The pain is described as constricting, squeezing, choking, or even substernal discomfort. Angina, and it is 3 clinical types, was discussed previously by our colleagues in the previous seminar, so I mention it only. Then I will talk about the second clinical type of ischemic heart disease, which is the most important type, and it is myocardial infarction. What do we mean by myocardial infarction? It is a heart attack. It is irreversible death or necrosis of myocardium secondary to prolonged lack of oxygen supply to the perfused myocardium. While MI can occur at virtually any age, the frequency will rise progressively with aging and with increasing the risk factor for atherosclerosis. The advanced studies suggest that approximately 1.5 million cases of MI occur annually in the United States. Now, pathogenesis of MI. The vast majority of MI are caused by acute thrombosis within the coronary artery. In most instances, there will be a disruption or erosion of a pre-existing atherosclerotic plaque. This serves as the needles for thrombus generation, and this will lead to vascular occlusion and then subsequent infarction of the perfused myocardium. In about 10% of MI, however, transmural infarction can occur in the absence of occlusive atherosclerotic vascular disease. This picture will demonstrate the mechanism for developing MI. Here, as we can see here, thermomatous plaque. Thermomatous plaque is eroded or suddenly disrupted, leading to endothelial injury, and then subendothelial collagen exposing. The platelet will adhere, aggregates, and are activated, releasing thromboxane A2, adenosine diphosphate, and serotonin. This will causing further platelet aggregation and vasospasm. Within a minute, the thrombus can evolve to completely occlude the coronary artery lumen with the developing of ischemia or necrosis in the perfused myocardium. Now, the morphology of MI. Nearly all transmural infarction involve at least a portion of the left ventricle, while isolated infarction of the right ventricle occur in up to 3% of the cases, and the presence of multiple severe stenosis or thrombosis in the absence of infarction suggests protection by collaterals. This picture will demonstrate the pattern of distribution myocardial ischemic necrosis with location and nature of decreased perfusion. This is a heart section. This is the anterior wall, and this is the posterior wall. This is the left ventricle, and this is the right ventricle. This is the left anterior descending branch of left coronary artery. This is the left circumflex branch of left coronary artery, and this is the right coronary artery. When there is narrowing or complete thrombosis within the left anterior descending branch of left coronary artery, the infarction will involve the anterior wall of the left ventricle, the anterior portion of the ventricular septum, and the apex circumferentially. While if the narrowing involving the left circumflex branch of left coronary artery, the infarction will involve the lateral wall of the left ventricle except the apex. While when the narrowing involving the right coronary artery, the infarction will involve the posterior wall of the left ventricle, the posterior portion of the ventricular septum, and the posterior wall of the right ventricle. The continuation will be with my colleague.
Assalamu alaikum. I am Mohammed Moteaa, and I will talk about the gross morphology of MI. Infarcts less than 12 hours are usually not apparent grossly, but can be demonstrated by solution that's called triphenyl tetrazolium chloride. This cross-section through the heart, which shows the larger left ventricular chamber and the right ventricle. We will see that the myocardial infarction will extend from the anterior chamber and pass into the septum. This infarction is called transmural infarction because it involves the full thickness of the ventricular wall. Infarct older than 12 to 24 hours appears red or blue, that's called stagnant blood, but progressively becomes yellow or tan. By 3 to 7 days is ruined by hyperemia or central yellow tan. Over weeks, scar will develop microscopically. Now, we will show for you some slides that will make the object more obvious. The left slide will show the normal myocardium. We will see myocardial nucleus, capillary, and inside of it there are red blood cells, and the last arrow will show intercalated disc. The right slide will show the MI after 18 hours. We will see loss of nucleus and contraction bands. The left slide here will show the MI after 18 to 24 hours. We will see loss of nucleus, contraction bands, and coagulative necrosis. The right slide will show the MI after 1 day. We will see loss of nucleus, contraction bands, and a few neutrophils. Now, we will talk about the MI after 1 to 2 days in this slide. We will see the following features. Number 1, the myocardial fibers have dark red contraction bands extending across them. Number 2, the myocardial cell nuclei have almost all disappeared. And 3, there is beginning of acute inflammation. The right slide will show the MI after 1 to 3 days. There is an extensive acute inflammatory cell infiltrate, and many neutrophils are undergoing karyorrhexis. And the myocardial fibers are undergoing necrosis so that the outlines of them are not well defined. The left slide here will show the MI after 1 to 3 weeks. We will see that there are remaining of normal myocardial fibers at the top. Below these fibers there are macrophages with numerous capillaries and little collagenization. The right slide will show the MI after 3 to 6 weeks. We will see that the intermediate myocardial infarction shown involving a papillary muscle with decreasing cellularity and more prominence of collagen. But there are remaining of normal red myocardial fibers, and cardiac biomarkers are not positive at this stage, and the myocardial rupture is unlikely. And the last slide here will show the MI after 6 years. We will see collagen scar, but there is no inflammation. Now, we will talk about the myocardial response in MI. The first response is the biochemical response. Within seconds, we will see cessation of aerobic glycolysis, and as a result, accumulation of lactic acid. The second response is the functional response. Within 60 seconds of ischemic onset, we will see loss of contractility, and as a result, acute heart failure. And the last response, which is the morphological response. After 20 to 40 minutes, we will see ischemia. And after that, necrosis, irreversible injury first in the subendocardial region, and after that becomes transmural. Based on the size of the involved vessel occluded and the degree of collateral circulation, myocardial infarcts may take one of the following patterns. First, transmural infarctions involve the full thickness of the ventricle and are caused by epicardial vessel occlusion through a combination of chronic atherosclerosis and acute thrombosis. 2. Subendocardial infarctions, which are infarctions limited to the inner third of the myocardium. The subendocardial region is most vulnerable to hypoperfusion and hypoxia. We will see in this slide subendocardial infarction, which occupy the inner third of the normal myocardium, and transmural infarction, which involve the full thickness of the myocardium, and the subepicardial infarction, which involve the outer third of myocardium. Now, my colleague Hadeel Emad will complete the presentation. Thank you.
I am Hadeel Emad, and now we will talk about the clinical feature of MI. The classic MI is heralded by severe crushing substernal chest pain or pressure that can radiate to the neck, jaw, epigastrium, or left arm. In contrast to angina pectoris, the associated pain typically lasts several minutes to hours and is not relieved by nitroglycerin or rest. However, in a substantial minority of patients, 10 to 15%, MI present with atypical signs and symptoms and may even be entirely asymptomatic. Such silent infarcts are particularly common in patients with underlying diabetes mellitus, in which autonomic neuropathy may prevent perception of pain, and it also occurs in older adults. Other clinical features include the pulse generally is rapid and weak, and the patients are often sweating and nauseous. Also, dyspnea is common, resulting from impaired myocardial contractility and dysfunction of the mitral valve apparatus, with resultant acute pulmonary congestion and edema. In massive MI involving more than 40% of the left ventricle, cardiogenic shock may develop. The consequence and complication of MI include contractile dysfunction, papillary muscle dysfunction, right ventricular infarction, myocardial rupture, arrhythmias, pericarditis and Whistler syndrome, chamber dilation, mural thrombus, ventricular aneurysm, and lead to progressive late heart failure. As we can see here, we have myocardial rupture, septum rupture, papillary muscle rupture, fibrous pericarditis, mural thrombus, and aneurysm. Now the laboratory diagnosis. The laboratory evaluation of MI is based on measuring blood levels of macromolecules that leak out of the injured myocardial cell through damaged cell membrane. These molecules include myoglobulin, cardiac troponin T and I, creatine kinase NB, and lactate dehydrogenase. Troponin and to lesser extent creatine kinase NB have a high specificity and sensitivity of myocardial damage. The creatine kinase NB isoform, principally derived from myocardium, but also present at low levels in skeletal muscle, is a more specific indicator of heart damage. Creatine kinase NB activity begin to rise within 2 to 4 hours of MI, peak at 24 to 48 hours, and return to normal within approximately 72 hours. Troponin normally is not found in the circulation. However, after acute MI is detectable within 2 to 4 hours, with levels peaking at 7 to 10 days. With reperfusion, both troponin and creatine kinase NB level per peak earlier owing to more rapid washout of the enzyme from the necrotic tissue. Now, the third class of the ischemic heart disease, which is the sudden cardiac death. Sudden cardiac death is an unexpected death from cardiac causes early after symptoms. It occurs due to one of these causes: coronary artery occlusion due to atherosclerotic plaque, thrombus, platelet aggregates, or embolus; coronary artery aneurysm or rupture associated with Kawasaki disease, vasculitis, connective tissue disease; coronary artery dissection, often in young females, multifocal and associated with increased eosinophils; arthritis, coronary artery spasm, or congenital anomalies of coronary vessels due to abnormal origin and course, osteal malformation, hypoplasia, or coronary artery tunneling. The last class of ischemic heart disease, which is the chronic ischemic heart disease, also called ischemic cardiomyopathy, is a progressive heart failure secondary to ischemic myocardial damage. In most instances, there is a known clinical history of previous MI. After a prior infraction, chronic ischemic heart disease appears when the compensatory mechanism like hypertrophy of residual myocardium begin to fail. It is a low-grade ischemia. The morphology of that is: patient with ischemic heart disease typically exhibit left ventricular dilation and hypertrophy, often with discrete area of gray-white scarring from a previous health infarct. The endocardium generally show patchy fibrous thickening and mural thrombi may be present. The microscopic findings include myocardial hypertrophy, diffuse subendocardial myocyte vacuolization, and fibrosis from previous infraction. Thank you for your kind attention, and if there is any question, please tell us.